the key challenges faced by nurses in conducting research within Asia in their respective countries, and how can these challenges be addressed? So, please.
Thank you very much for the wonderful question. And before I start,
Just from the Hong Kong's experience, following the thoughts of the previous two speakers, I would like to, because
What do you envision as the ideal future state of nursing research, and how can the nursing profession adapt to emerging trends and challenges? So please, we'll demand.
Good morning and welcome. Thank you so much for joining me this morning. My name is Dr. Kiana Lacey, and I am speaking on behalf of the University of Texas, Arlington College of Nursing and Health Innovation. This morning, I will be presenting my project, Diabetes Risk Bundle for African American adults living in a rural East Texas community. I would like to give special acknowledgement to all of the staff and faculty at the University of Texas Arlington College of Nursing and Health Innovation, to my project faculty, Dr. Christy Nguyen, my project statistician, Dr. Young Fei Cao, and also to my local chapter, the Delta chapter of the Sigma Theta Tau International Honor Society. United States Services Task Force, along with the Centers for Disease Control and Prevention and the Healthy People 2030 Initiative, all identified diabetes mellitus as a critical health issue that demanded urgent attention. There are currently over 500 million cases of diabetes mellitus worldwide, and that number is only projected to increase to over 700 million by the year 2045. In the United States, there are over 37 million cases of diabetes mellitus, with the most common form being type 2 diabetes. Now, in the state in which I live, which is Texas, we have the highest prevalence of diabetes cases, with over 2.7 million cases each year. And in the image below, you can see the geographical regions that are highlighted according to diabetes prevalence rates. So a gap analysis was conducted which revealed two notable distinctions. The first was race. In the United States, over 5 million of the cases were among African Americans, and African Americans were twice as likely to die from type 2 diabetes when compared with other ethnicities and races. In the state of Texas, African Americans made up over half of the type 2 diabetes cases. And according to the CDC, type 2 diabetes is the 6th leading cause of death for this population. And in the graph below, you can see the disproportionate rate of type 2 diabetes cases amongst African American individuals. The second notable distinction was location. Now, according to the literature, rural cities in East Texas have the highest rate of type 2 diabetes cases when compared with other locations. And I believe that that happens for a myriad of reasons. For example, in Texas, rural cities are classified as food deserts, meaning that there are one or fewer grocery stores that provide access to healthy food items such as fresh fruits and vegetables. In addition, many rural cities in East Texas lack just basic access to health care. There are no primary care providers, there are no urgent care centers, or even hospital organizations. Many rural cities lack opportunities for physical activity. There are no gyms, there are no parks with walking trails, or even neighborhoods that have safe sidewalks. And furthermore, rural cities in East Texas lack public transportation, which hinders individuals' ability to access these items. A systematic and methodical review of the literature was conducted to explore interventions that could help mitigate these gaps. The literature did reveal stark disparities in outcomes when it came to African American patients. For example, African Americans had a significantly this project that consisted of 3 different phases. The first being the preparation phase. In this phase, the project team was assembled, which consisted of myself, the project lead, an administrative nurse assistant, a communication director, and also the executive director of our project site. During this phase, we went over team orientation, the script, the schedule, the planning, and the recruitment phase took place. Recruitment took place by handing out flyers within the rural community at local grocery store. Well, they have one grocery store, so we handed out flyers there. We went to the fast food restaurants, the drive-thrus, the library, and also the post office to invite individuals to participate in our project. The next phase was the pre-intervention assessment phase, even access to physical activity. Going forward, I do believe that funding should be explored at the city, state, and federal level to implement things that would increase our participants' access. For example, the addition of maybe a park with public areas to walk in, the addition of a community garden, or maybe a food market on the weekend. And also funding should be explored for the addition of primary care providers within the actual city limits. As a healthcare provider, I would say just the insights that we learned was the fact that there are social determinants of health that do affect our patient outcomes. I believe that we should be culturally competent and just consider those determinants when providing care to our patients, and just to realize that there may be additional factors or mitigating factors that prevent our patients from being able to adhere to the guidelines and to the recommendations that we make. And as healthcare providers, I would encourage us to seek opportunities for innovation to help our patients access the treatment that they need. There were limitations with this project. The main one was time. This commenced over 8 weeks, and I would like to implement this again over a longer time period. Another was the risk for attrition. However, I believe that was mitigated just by the giveaways that gave our participants incentives to want to return. There are implications with this project. There were significant differences with the diabetes risk bundle, and it did appear to have an effect on our population. I do believe that it is a cost-effective and efficient way to help increase population's knowledge and also to provide resources for at-risk populations. The DRB, or Diabetes Risk Bundle, would have the potential to save over $245 billion each year in unnecessary emergency department visits, healthcare treatment, and also I do believe that it could help alleviate the burden on an already stressed and strained healthcare force. And here are my